So now we come back to my patient that I was working with. So in the ER, he rated his pain at a 10 on a scale from 0 to 10, with tenderness upon palpation to his abdomen. So he was portraying those key signs of acute pancreatitis. The pain was described as stabbing and aching. So we drew his labs that we just talked about. We drew some blood, and that showed some elevated serum lipase levels, elevated serum blood alcohol level, decreased serum red blood cell count, and decreased serum sodium level. He also had a CT scan, which showed free fluid that was found in the pancreas. So due to his pain being so high, and we know that pain can inhibit healing, we want to control his pain to make him more comfortable. So that brings us to the nursing diagnosis of acute pain related to the diagnosis of acute pancreatitis, as evidenced by a pain scale rating of a 10 on a scale from 0 to 10, verbalization of a stabbing, sharp pain to the abdomen, and elevated serum lipase levels. So again, looking at Maslow's hierarchy of needs, we have the basic, most physiological needs to come first. We want to control his pain in order to promote healing. So we have some treatment options. First, we have drug therapy, IV morphine to decrease pain, antispasmodics to control the pancreatic outflow and vagal stimulation, Diamox and antacids to decrease or neutralize pancreatic enzyme release, antibiotics to prevent the risk of infection in patients with necrosis or pancreatic tissues. We want to hydrate patients with IV fluids. Lactated ringers and normal saline are used. Most often lactated ringers because it has those supplemental electrolytes that are needed to improve the nutritional status for our patients that have been vomiting. We want our patients to be on an NPO diet, and there may be an NG tube insertion to be placed because we want the pancreas and the stomach to rest so that those enzymes are not produced. Surgical therapy could be indicated. We may want to drain the accumulation of necrotic fluid. An ERCP could also be completed for gallstones. Nutritional therapy would include low-fat dietary guidelines. And we have enteral nutrition. I also found another interesting study by Nutritional Management in Acute Pancreatitis was the title. And they found that the administration of enteral nutrition within the first 48 hours of onset of acute pancreatitis actually minimizes the risk of infection and the length of hospital stays as compared to parenteral nutrition. So they were looking up gut browsing versus pancreatic rest, being that it places higher importance on nutrition rather than the resting part of the pancreas. So the patient was still receiving nutrition to maintain the function of the intestines. Now we come to some collaborative care. So we have a couple goals for our patient. So prior to the date of discharge, the patient will verbalize a decrease in the amount of pain related to the diagnosis of acute pancreatitis. So then we have 4 interventions that allow us to meet these goals. So we want to administer prescribed pain medications in an efficient manner. Again, we really want to control that pain so that our patients can heal. We want them to be comfortable. Intervention 2, complete accurate pain assessments and reassessments in a prompt fashion. We want to be following up with these patients so that we know if their pain medication is effective, if their pain is being controlled. Intervention 3, monitoring routine vital signs and report significant changes to the primary care provider. As we know in nursing, vital signs can indicate pain, elevated blood pressures, respiratory rate, heart rate. Intervention number 4, initiate non-pharmacological interventions to reduce pain through the implementation of cold packs, music, visual imagery, and deep breathing exercises. Again, those non-pharmacological interventions, they provide an option to decrease pain without the side effects of the medications. We know that our pain medications that we use slow our systems down, slow our nervous systems down. So it causes some constipation, it causes respiratory slowing of the respiratory rate. So we really want to limit those if we can. So providing non-pharmacological ways to control pain is essential. We also have another goal for our patient. So prior to the date of discharge, the patient will maintain sufficient nutritional and fluid balances for individual body requirements, with evidence that displays tolerance to advanced diet and output that is within normal limits. So we have 4 more interventions here. The first intervention is to provide assistance to the patient regarding the selection of food choices, which adhere to the recommended dietary guidelines for acute pancreatitis. We want our patient to go home and recognize which foods they should be eating that adhere to that low-fat diet. We need them to have education so that they know what to do at home. Intervention 2, encourage an advanced diet as tolerated by slowly initiating clear liquids and ending with a general low-fat diet. So then the rationale for this, beginning with easier foods for the stomach to digest, that's the best approach for the patient to tolerate it before we advance to more complicated food items. Intervention number 3, monitoring the patients for signs of intolerance to that advanced diet. So again, paying attention to any episodes of nausea and vomiting that could indicate that the patient is not agreeing with the advanced diet. And intervention 4, assessing the patient's bowel and bladder habits while noting the amount, color, and consistency of output. Again, focusing on that output will tell us of our patient's nutritional status. So looking at the appearance of the bowel and bladder habits will help us decipher if the patient is receiving adequate nutrition. So now we come back to my patient. So after the ER visit, the patient was admitted to the medical surgical floor. The plan of care followed that of a standard acute pancreatitis patient. He was placed on the MPO diet. He had normal saline running at 75 milliliters per hour to keep him hydrated. He had some IV pain medication ordered, which was Dilaudid, every 4 hours as needed. He had docusate sodium, again for that constipation, the IV protonics to control that GERD or that heartburn feeling, chest pain. And then we have subcutaneous injection of Lovenox, again, to prevent the risk of blood clotting. The patient was ordered to have his labs drawn again the next day, and his labs the next day indicated a decrease in serum lipase levels, but they were still outside of normal ranges. The doctor assessed the patient and ordered the remaining normal saline to transfuse as a bolus. As we talked previously, the patient needs to be hydrated, so he ordered that to transfuse more rapidly. His diet was advanced to a general diet, and he tolerated a piece of toast and a hot chocolate. And the patient was discharged home with discharge instructions and education as needed. And some references for you. And that is it. Thank you.